Hi Charles, how you doing?
I'm doing well, Pablo. How are you?
Good too, thank you. Good to see
Excellent.
you.
Nice to see you as well.
Even
I
though it
think
has to be this way now.
I know it's unfortunate. My wife and I
La
had
Pablo.
booked a 10-day vacation trip to Chile for this last year, but we had to postpone it to 2021. Hopefully, we'll be okay then.
Hopefully we have you over here then.
That would be good. We would like that.
Ok, entonces en 2 minutos más vamos a dar inicio al seminario. Voy a poner una imagen.
In 2 minutes, we're going to start. I'm going to put an image on the screen, and you have to turn off your camera. We will see a commercial of the industry first. And Dr. Beltran will then welcome everyone. And after that, we have a very short commercial. No, but I have to introduce Pablo. Please tell me, how should I introduce you? GSK, as medical manager of GlaxoSmithKline Chile. Please repeat. Medical manager for HIV area. Medical manager for HIV area from GlaxoSmithKline Chile. Yes.
Nada de inmunólogo.
Nothing to do with immunologist. Well, I'm clinical immunologist, medical manager of HIV area. All right. We will start by the virtual stand of the whole industry. I welcome everyone. I introduce you, and then we see the video, right? Or after you speak. No, please show the video. Then I speak and I introduce Dr. Hicks. You have all of his affiliations and everything, right? Yes. Good. We will start.
Sí.
El compromiso de Gilead por una eventual erradicación del VIH ha sido firme. Hemos seguido progresando constantemente con medicamentos efectivos que se han vuelto progresivamente más simples de tomar, más fáciles de tolerar y más seguros a largo plazo. Por lo tanto, el VIH se ha convertido en una enfermedad crónica tratable. En América Latina, cada vez más y más pacientes tienen acceso a nuestras terapias innovadoras que salvan vidas y mejoran su calidad de vida. Nuestro compromiso es permanente y aún queda un largo camino por recorrer, pero está en nuestras manos triunfar. Debemos continuar trabajando y hacer posible, y no solo lograr que nuestros pacientes sean indetectables, sino también a un estado de salud y bienestar integral.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de 2 drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir, alafenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.
Bien, buenas tardes, estimados
Good afternoon.
asistentes a esta segunda jornada del tercer Improving Standard virtual.
Good afternoon. We're starting this third day. Once again, we have a very interesting day in this course. We will have 2 symposia. The first one is an industry symposium, VIP GSK, analyzing the current reality of the paradigm change from 3 drug therapy to 2 drug therapy. And the second symposium by Dr. Pablo Parenti is the immediate future of antiretroviral therapy. As you can see today, we will be very concentrated on antiretroviral therapy in itself. I would like to welcome the 480 or more attendees in the third Improving Standards from over 15 countries all around Latin America, Central America, Mexico, the Caribbean, all of South America. We are sure that you will enjoy today's course just as occurred with yesterday's course. Without further ado, I will begin the first symposium, Vil GSK, about dolutegravir 3TC. What have we learned throughout the years? We have as a chairman, Dr. Pablo Herrera, clinical immunologist and general manager of the HIV area from GSK Chile. He will moderate this symposium and he will introduce the official speaker.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de dos drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir a la fenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.
Muy buenas tardes. Muchas gracias, doctor Beltrán, por la...
Good afternoon, and thank you, Dr. Beltran, for this introduction. Thanks to the organizers of this very important event for allowing us to participate in this space and with this activity, with this important symposium to speak about 2-drug therapy. For us, it is an honor to participate of this important international event and to be able to count on our speaker in the dolutegravir lamivudine therapy by Dr. Charles Higgs, an expert in the HIV area. Dr. Higgs is the global senior GSK manager, medical manager in the medical center, working also in the medical center of Duke and California, San Diego. He was the director of the Owen Clinic of the University of California, San Diego. This is the HIV clinic of the university before joining Bill Healthcare. During his years of academia, he was author of over 100 papers, peer-reviewed papers, and he became professor of medicine. He has been an author of many studies about antiretroviral therapy. He has also worked in a broad number of groups of review and also membership in the panel of guidelines of antiretroviral therapy from the DHHS of the US. Without further ado, he doesn't require any more introduction. I leave to you, Dr. Higgs, who will give us this very interesting lecture. Dr. Higgs, welcome. You can begin your lecture right now.
Thank you so much, Pablo. It's a great honor for me to join you today. I wish I could do that in person. I've had so many wonderful trips to South and Central America and Chile, and I'm very sad to have to do this from my home today, but I hope this will be a worthwhile presentation for you and that there will be information of value that you can use in your practice as we make our way through our talk today. So let me make this into full screen and make it into presentation mode, and we'll get started. So as was mentioned in the introduction, I am a senior global medical director at VIV Healthcare. And obviously that means I'm a full-time employee at VIV Healthcare. And so my comments are obviously influenced by my position, but I always try to remain as objective as I can. After many years in academic medicine, I value that very much. And I hope the evidence I present to you today will reflect my objectivity as I review the data. Well, as we discuss the topic of 2-drug therapy, it's probably a good idea to start with the most obvious question, which is, if we are considering a change to our current approach to treatment, then what's wrong with what we are doing now? We have used 3-drug antiretroviral therapy successfully for more than 20 years. Why do we need to switch? Well, let's take a look at some data that suggests a reason why switching to a 2-drug regimen may be a rational choice in 2020. If we go back to the beginning of this period of time represented on this graph, 1996-97, some of you who are older, like me, may remember the International AIDS meeting in Vancouver in 1996, where the results of 3 drug combinations, including HIV protease inhibitors, showed for the first time that it was possible to control viral replication and thereby make a very meaningful difference in the lives of people living with HIV. And you may appreciate that in 1996, a 20-year-old person who became infected, on average, would live about 19 more years. But here we see the impact of this better therapy as survival gets improved in the ensuing 5 years. And this improvement continues along this line so that by 2011, the difference between a person without HIV and a person living with HIV has become only 12 years. And this gap in survival continues to shrink as our better therapies and our improved inclusion of persons into HIV care allows more people to live longer lives. But you'll also appreciate that if you are here and you wish to get here, it means that you have to remain on therapy for a very long period of time. So what does that mean in terms of actually taking treatment? Well, here are 3 different types of antiretroviral regimens. Here is a boosted 3-drug regimen, perhaps a boosted PI. Here is a standard 3-drug regimen, and here is a 2-drug regimen. And you can see over the course of a year, this boosted regimen requires a person living with HIV to take 1,460 doses of medicine a year. A 2-drug regimen is half that, 730. Now that's a lot of medicine, but if we look over a longer period of time, here in this paper published in AIDS in 2012, a period of 39 years, you can see these numbers become rather extraordinary. 57,000 doses of medicine over that period for a boosted 3-drug regimen, half that, 28,543 for a 2-drug regimen. So one issue perhaps we should be thinking about is what is the cumulative lifetime effect of being exposed to these medicines for very extended periods of time. The second question we might ask is, what do people living with HIV think about this? Here's data from a discussion, a study in which people living with HIV were asked questions about their medication to determine what they thought were some of the most important factors in a successful regimen. And you can see that near the top is reduction of long-term effects of the medicine on the body and longer lasting treatment, so it can be taken less often. Clearly, side effects are important, but also I can take less medicine and get the same effect. So these are all issues that this group of people living with HIV suggested were important to them in creating a good regimen for them to be taking. One other issue that I think we need to respect is the issue of long-term toxicity. Now, in the many years that I have been seeing patients who are HIV positive, I have become very aware that treatments that we initially greet with great enthusiasm, that we think have very few side effects or problems, can change their characteristics as people take them longer. For example, if you're old enough to remember stavudine, also called D4T, which was approved in the US in 1994, you may recall how enthusiastic we were about the availability of this drug because the side effects seemed to be so much less than what we saw with patients taking zidovudine or AZT. But as we used the drug longer, we began to notice this side effect called lipoatrophy. And 5 years after its introduction, we were now no longer very enthusiastic about stavudine because this was a very unpleasant side effect, and there didn't appear to be a treatment for it. Similarly, you can see other toxicities that emerged years, even more than 10 years after the drug was first introduced into clinical practice. And I would argue that every drug, 100% of the medicines we use have side effects, many of which we don't appreciate until after we've used the drug for a significant length of time. So the treatments we have today, which seem to be very well tolerated, may emerge in the future with consequences we currently do not anticipate. And this suggests also to me that if we can diminish the number of drugs, we can potentially reduce the number of people who might suffer those long-term side effects. So if you then accept my argument that a goal for better therapy would be to reduce overall exposure to antiretrovirals over the decades people will have to take them. And I should mention here, if we are fortunate enough to develop a cure for HIV, then many of these issues will become less relevant, clearly. However, my interpretation of our current situation is that we are quite a long ways from understanding what's required to cure HIV in the population of people living with HIV. So therefore, we need to now focus on this notion that we should reduce exposure if it is safe, if the treatments remain effective. So how might we reduce exposure? Well, we could reduce the drug dose. For example, efavirenz at 400 milligrams in many studies appears to be comparable to efavirenz dosed at 600 milligrams. So reducing the drug dose might be one strategy. Tenofovir is a drug that has some recognized toxicity, which is reduced when the TDF version is replaced by TAF. We don't yet know if there are going to be consequences from the very high concentrations of tenofovir intracellularly that are characteristic of TAF dosing, but clearly the systemic exposure to tenofovir is lower with TAF than with TDF. I think we should try as much as is possible to get rid of pharmacokinetic boosters, boosted protease inhibitors, and some other drugs, because they add toxicity without doing anything other than taking a drug with insufficient pharmacokinetic characteristics and making it functional by blocking normal metabolic enzymes in the body. If we can be successful without boosters, I think that is a direction we should try to take. And finally, might it be possible in the current era with the drugs we have today to be successful with fewer drugs? For many years, we've emphasized to our students, to patients, that it is essential to combine 3 active agents to achieve consistent virologic suppression. Is it possible with the agents we have available to us today, in particular with HIV integrase inhibitors, is it possible that 2 drugs may be sufficient? So let's think about this in the sense of a clinic, and let's think about a setting where the idea of switching to two drugs emerges as part of the patient management. This patient we'll call CD is a 59-year-old man who was diagnosed with HIV in 2005 and was started on a protease inhibitor-based treatment regimen, which he tolerated well and has taken consistently with no history of treatment failure. He's currently on darunavir, cobicistat as a booster, and TAF-FTC in a combination dose. He has developed abnormal lipid profile for which his provider has prescribed atorvastatin for improvements in his lipid parameters and to reduce the risk of complications related to elevated lipids. He now comes into the clinic after being on these medicines for a few months and reports that he has soreness in his arms and legs and that his urine has become quite dark. Here you can see his laboratory values at the time he started atorvastatin. When you do an exam, you note that he is obese. He has diffuse muscle tenderness, quite prominent in his arms and legs. And his laboratory data reveal an elevated CK and an abnormal creatinine, suggesting early renal insufficiency. Based on the history, the exam, and these laboratory data, the diagnosis appears to be rhabdomyolysis, and this appears to be, in turn, a consequence of a drug interaction between his booster, cobicistat, and the statin he was given, atorvastatin. And therefore, his atorvastatin is discontinued, and his antiretroviral regimen is changed to eliminate the use of a booster, and he started on the two-drug regimen, dolutegravir and lamivudine. 2 weeks later, he comes back to see his healthcare provider and notes that his muscle soreness has gone away, and he tells you he's tolerating his new antiretroviral therapy quite well. A repeat of his laboratory profile shows improvement in his CK and renal function, and so he's continued on dolutegravir 3-TC, and his HIV RNA remains below the level of detection. So here's an example of a switch which was brought about by a complication related to his treatment. And as this slide shows, there may be many reasons for wanting to switch to an alternative therapy. In this instance, it was to reduce the risk of drug-drug interactions. Here, an obvious reason to change his regimen, and in this case, the two-drug regimen appeared to work well. It is notable that the two-drug combination of dolutegravir and lamivudine has the lowest potential for drug-drug interaction with commonly prescribed non-antiretroviral drugs than any other combination that's in clinical use. And so one potential advantage then, if this two-drug regimen is sufficiently potent and efficacious, might be that the risks of drug-drug interactions diminish, an issue that is probably increasingly important as the people we care for in our clinics are older and older and develop many morbidities related to aging, which require other medications. So with that preparatory comment, I would like to now discuss some of the data on this two-drug combination and to try and see if we could plausibly say that dolutegravir plus lamivudine is a good antiretroviral regimen by itself. I think to understand what we know, it's helpful to look at some of the characteristics of dolutegravir, because I think it is really the availability of dolutegravir that has made this possible. Lamivudine, also an exceptional drug, has been around in practice for more than 20 years. It is generic and inexpensive. It remains part of recommended regimens of virtually all the guidelines that are currently published, as we'll review at the end of this presentation. So it's going to turn out to be an important component of this two-drug regimen. But let's take a quick look at characteristics of dolutegravir to understand why it might be the key to this successful combination. As with all integrase inhibitors, particularly the so-called second-generation integrase inhibitors, it has rapid and potent antiretroviral activity. Viral loads are suppressed more rapidly with HIV integrase inhibitors after therapy initiation than any other combinations. And happily, one thing we've determined as we've learned more about these second-generation integrase inhibitors, dolutegravir and bictegravir, is that they have a high barrier to resistance. And we'll see the verification of this as we go through the data. Dolutegravir binds to its binding site in integrase in wild-type virus for an extended period of time, improving the duration of action of the drug in the individual patient. And as dolutegravir was approved in the US in 2013, we now have quite a collection of data that allows us to characterize the clinical efficacy of this drug. As mentioned, a long half-life, a good pharmacokinetics that allow for good exposure in a wide range of different patients, excellent tolerability data, and as we've seen, low potential for drug-drug interactions. All of these things help define dolutegravir as a characteristic drug that has advantages we may be able to take advantage of with our two-drug regimens. So now I want to briefly review the clinical trials data that have allowed licensing of the drug and have allowed it now to be available worldwide as part of combination antiretroviral therapy. These are drugs that, this is data on the two-drug regimen of dolutegravir plus lamivudine. And here I would like to credit and mention my friend Pedro Kahn from Argentina, who really championed this idea of two-drug therapy and whose enthusiasm for these studies really has allowed this process to move forward. And he is, of course, the lead author on the Gemini trials, which I'll now discuss with you. Gemini 1 and 2 are identical studies conducted in different countries that enrolled persons who were treatment naive, that is HIV infected, but had not been put on therapy yet, to receive either the two-drug regimen of dolutegravir plus lamivudine or a three-drug combination, dolutegravir plus TDF-FTC. Now, some ask, why TDF? Why not TAF? Well, the primary reason is that at the time this study was initiated, TAF was not available in many of the countries where the trial was being conducted. And it is essential when you do a clinical trial in a country that that therapy be available to the citizens of that country after the trial results are known, if in fact this therapy is successful. So TDF clearly was the right choice for this combination study. The trial now has been ongoing long enough that earlier this year, the 3-year or week 144 follow-up data were presented. Of note, in the entry criteria, people needed to have no major RT or PI resistance mutations and could not have active hepatitis B infection or have a need for hepatitis C treatment during the period. The population in this study is large since it's combining two individual studies. 716 persons are randomized to the two-drug therapy, 717 to the standard of care three-drug therapy. And about 15% of the persons enrolling in the trial were female at birth. The trial included about 2/3 Caucasians, white people, and the remainder were non-white persons of a variety of backgrounds. 20% of the persons enrolled in the trial had a viral load greater than 100,000, but only 9 or 8% had a CD4 count less than 200. And so this relatively small number of people with lower CD4 counts may complicate the interpretation of some of the data on this study. Now, here are the virologic results, perhaps the most important slide in this part of the presentation. The orange line represents the proportion of persons with viral load less than 50 copies at the various measurement time points. The darker line, which is either blue or black, depending on how it appears on your screen, shows the proportion of persons with viral load less than 50 copies on the two-drug regimen. And it's quite clear as you look at this that there is no difference in virologic suppression rates. In fact, the two-drug regimen was clearly not inferior to the standard of care three-drug regimen. If we look at it in subgroups, here persons with viral load less than 100,000, 81 versus 84%, here greater than 100,000, 82 versus 84, here CD4 counts greater than 200, 83 versus 84, and here, interestingly, a population of 63 and 55 patients with a CD4 count less than 200. And here we see there might be a difference, 76% in the three-drug arm, 67% in the two-drug arm. When these data were investigated more carefully, there was no difference in the rates of failure due to virologic outcomes. The difference occurred in people who had no virologic data, who had dropped out of the study, who had been incarcerated, who had been switched to alternative regimens by their providers. So although this is a difference, it appears mostly to be explained not by virologic outcomes. Well, what about resistance? What about virologic withdrawal? Remember, this is 3 years of follow-up of over 700 patients. In that 3-year period, there are 12 persons in the two-drug arm, less than 2% over 3 years, who have virologic failure, who have a confirmed virologic withdrawal. Only one of which occurred between the start of year 3 and the week 144 visit. And none of these 12 or none of these 9 on 3-drug therapy had evidence of resistance at the time of failure. Now, it's important to point out, though, that there was one patient who actually did not qualify for the criterion confirmed virologic failure, who in fact did develop resistance on the two-drug combination. This person had been fully suppressed for more than 2 years, but had a difficult time in his life, which resulted in very poor adherence. And his local provider in the clinic outside the study did a resistance test when his viral load came back 61,000 and found that he had developed M184V during this period of very poor treatment adherence. When he was then referred back to the study and seen at study week 144, a resistance test done through the study confirmed M184V and also identified an integrase mutation at position 263, which was a mixture of R and K at a time when his viral load was 135 and he was back on therapy. This mutation produced a 1.8-fold change in susceptibility of dolutegravir, which suggests that dolutegravir was still a fully active agent, but clearly this patient needed to be on alternative therapy, and he was switched and became fully suppressed. So let's turn now to adverse events. Again, you'll appreciate that a 2-drug regimen compared to a 3-drug regimen, our expectation would be that this would likely have fewer drug-related adverse events. And in fact, when we go down to that category, we see that there is a difference with fewer events occurring in the 2-drug arm. And remember, this is a blinded study, so neither the provider nor the person taking the medication knew which medicine they were on. Similarly, adverse events leading to withdrawal did not differ meaningfully between the 2 arms, and serious adverse events were seen somewhat more frequently with the 3-drug regimen, but were not statistically significantly different. Okay, so that's treatment in initial therapy in treatment-naive patients. Let's look at what has turned out so far to be a more popular choice for providers in how they like to use 2-drug regimens, and that's in a switching setting. So to do this, we'll examine the results from the TANGO study. These were also reported earlier this year at the meeting in Glasgow, as were the 3-year results from Gemini. TANGO was designed to enroll persons who were virologically suppressed for at least 6 months on a TAF-based regimen. And they were randomized to switch to the 2-drug dolutegravir 3TC combination or remain on their TAF-based 3-drug or 4-drug regimen, and then followed through 3 years of randomization. This study started later than the Gemini study, and so the data available in Glasgow was the 2-year or 96-week data. Here we see the population. It's not as large as Gemini, but still about 369, 372 in the 2 treatment arms. In this study, unfortunately, the proportion of persons female at birth was smaller, and again, the population was mostly white Caucasians. These are people that have been suppressed. They're on TAF. They've been suppressed at least 6 months, and so their CD4 counts are quite good, 682, 720. You can see that on average, they've been on antiretroviral therapy for just under 3 years, 33 months, 35 months, and been on TAF for about 1.5 years at the time of enrollment. Most of them switched from an integrase inhibitor-based regimen. Here are the outcomes data at 2 years as reported in Glasgow. In a switch study, the current standard of reporting is to compare the proportion who had a HIV RNA greater than 50 at the evaluable time period. And you'll see here that in both arms, that number was quite low. In the people that remained on the 3-drug regimen, it was about 1%. In people who switched, it was even lower, less than 1% over 2 years. If we look instead at the more standard endpoint of proportion suppressed, we see the 2-year numbers are 86% for the 2-drug regimen, 79% for the 3-drug regimen, with the vast majority of the people not found to be less than 50 being recorded as having no virologic data at the time of the study visit. And you can see by these forest plots that there is no significant difference between the 2 arms, but that the median values and the confidence intervals are trending toward the two-drug regimen being more efficacious, although clearly all one can say is that the two-drug regimen was not inferior to the standard of care regimen. Now, if we look at this a little more closely, it's quite remarkable to look in the intent to treat analysis at the fact that there's only one person out of 369, one person over 2 years who had a viral load at an endpoint that was greater than 50. And this was a person who discontinued the trial for another reason and had a viral load greater than 50. There were 4 such persons in the TAF-containing regimen. And remember, these are people who on average had been fully suppressed on their TAF regimen for a period on average of 1.5 years, and on their overall therapy for an average of about 3 years. Let's look at the confirmed virologic withdrawals, again, through 2 years. In the two-drug arm, 0. In the TAF-containing regimen, 1 and 3 at week 96. No resistance seen in any of these patients for whom confirmed virologic withdrawal was the reason for their no longer being in the study. So for people who had expressed concerns that a two-drug regimen may be difficult because of the potential risk of emergence of resistance, I think these data in the switch study are very compelling. What about adverse events? Now remember, people coming into this had on average been taking the same TAF-based regimen for 1.5 years. So you're not surprised to see that there were not very many new incident adverse events reported. And even though the two-drug regimen has fewer medicines, it is a new regimen. And therefore, it was associated with a higher rate of drug-related adverse events. There was no difference in serious adverse events over the 2 years. And importantly, if we look between week 48, when the people had been on their selected regimen in the study for 1 year, and week 96, when they're now having a full 2 years of exposure to the drug, you can see that the difference that was seen early, because people were taking a new combination, has completely disappeared. And there is no difference in adverse events in the second year of the study. Okay, so that's efficacy results in treatment naive and treatment experienced patients. Let's take a look at safety. We've seen it in the 2 trials. Let's take a broader look at those issues. And I think as we discussed early in the presentation, the notion of long-term consequences of antiretroviral therapy really must be the focus of our considerations of the regimens we're using. And on this slide is a listing of some of the consequences we have identified in people taking antiretroviral therapy and living with HIV that I think are important for us to consider, including bone density issues, cardiovascular disease, diabetes, lipid problems, this strange phenomenon of lipoatrophy and lipoaccumulation, central nervous system side effects, kidney effects, and finally, weight gain, a problem that has recently surfaced and that is getting more attention in recent times. Let's look first at renal biomarkers in the Gemini trial of treatment-naive patients and the Tango switch trial. And you can see here that there are comparators in Gemini of various renal biomarkers. And in this study, the two-drug regimen was significantly better than the 3-drug TDF containing regimen at week 144. Perhaps not surprising, because we know that TDF has meaningful renal toxicity over the long term. Similarly for Tango, we're now in a situation where people are on TAF, and so the comparison is somewhat different, since we know TAF has very little renal toxicity. But we also know that integrase inhibitors, because of mechanisms related to creatinine disposition in the blood, generally causes decreased measurements of GFR unless we use cystatin C as our mechanism. And if we did that, we note that the decreases in the estimated GFR using cystatin C favored the 2-drug regimen at week 96. What about bone turnover? Again, we know TDF used in Gemini is associated with bone metabolism issues, and not surprisingly, changes in the bone biomarkers significantly favored the 2-drug dolutegravir lamivudine arm compared to the standard of care dolutegravir TDF FTC arm. What this means in the long term obviously remains to be determined, but in general, bone turnover concerns suggest the possibility of long-term issues related to osteopenia and osteoporosis. Interestingly, in 48-week data, which is all that has been obtained so far in the Tango trial, although the changes were relatively modest, in both treatment arms at week 48 and later at week 96, there was apparently more turnover in the 2-drug regimen than the 3-drug TAF-containing regimen, although you can see there's considerable variability among the measurements, and we still don't know for certainty which measurements are most important in determining long-term bone health. Well, what about real-world data? Many people, when I talk to HIV providers, will say, yes, your clinical trials are very impressive and interesting, but the patients I care for are not the same as people enrolled in clinical trials. And I want to know what is seen in so-called real-world populations. So here are data from 3 real-world studies, which appear to show some variability. For example, in 2 of these studies, there was no difference in bone mineral density, in this case in the hip, or in this case in the femur, but in all of these, there were meaningful improvements after switching to the 2-drug regimen in lumbar spine results of bone mineral density studies. Well, what about lipids? Here are the lipid changes in Gemini and in Tango. And to interpret these, we need to understand, as you probably well know, that TDF, for all its concerns with renal toxicity and bone toxicity, tends to have a favorable outcome on lipid levels. In fact, it is an agent that is associated with lower lipid levels. So here we've taken people off TDF, a lipid-lowering drug, and switched them to dolutegravir 3TC. And what we note is that, not surprisingly, lipid levels between baseline and week 96 favored the regimen that included TDF, except HDL cholesterol, the protective, if you will, the good cholesterol, was better in the DTG-3TC arm. And the ratio between cholesterol and HDL decreased about the same in both treatment arms. In contrast, where TAF-containing regimens were the comparator arm, in Tango, switching to dolutegravir 3TC was associated with improvements in most lipid parameters measured. How about real-world data? Here's a compilation of about 10 studies investigated between 2015 and 2019, and showed that in all but 2 of them, the switch to a 2-drug regimen led to lipid improvements compared to staying on a 3-drug regimen. In 2, there appeared to be no difference. Well, lastly, let's consider the issue of weight change, which has recently become a topic of increased interest, and I think something we're still learning a lot about. And I think it's fair to say that what we know today needs to be expanded as we look at more combinations and follow patients for longer periods of time. But I think we could note here, even though we shouldn't do cross-study comparisons, but we can note here that in a variety of different regimens, it appears that the newer generation integrase inhibitors were generally associated with more significant weight increases than when those drugs were not part of the regimen, as you see here in this efavirenz-containing arm. And it appears that TAF was associated with higher rates of weight gain compared to TDF, and in this case, TAF compared to abacavir. In fact, this later observation was also seen in an analysis of Gilead trials done by Dr. Paul Sachs and published in Clinical Infectious Diseases, and noted that the greatest weight gains in the advanced study done in South Africa were seen in those who were randomized to TAF-containing regimens, and that in fact the TAF combinations were significantly more likely to be associated with weight gain exceeding 10% than were other nucleoside combinations. All right, as we close, let me talk briefly about guidelines, and then we'll try and summarize the information we have. There are many guidelines, and I'm only going to show a few here. The IAS USA guidelines were recently updated after this summer's IAS World AIDS meeting. The DHHS guidelines, which I was a member of prior to joining VIV, have not been updated for the last year. And part of that is related to the disruption caused by COVID-19 and the inability to draw together the members of the board to discuss potential changes. So they're among the more outdated, if you will, guidelines we have. The European AIDS Clinical Society guidelines were updated very recently. And finally, at the bottom, the World Health Organization guidelines also have not been updated very recently. Here are the updates as seen in the World Health Organization and DHHS guidelines are from last year. But importantly, in all of these guidelines, except the World Health Organization guidelines, dolutegravir 3TC, either as a combination tablet or the 2 drugs used separately together, is recommended in all the guidelines except the WHO guidelines. And those of you more familiar with WHO guidelines appreciate that they are very focused on the idea that when they issue guidelines, they should be applicable to all populations, older people, pregnancy, adolescents, and children. So they tend to lag many of the other guidelines. Here you see the current recommendation table from IAS USA, DHHS, and the European Guidelines Committee. Here's dolutegravir 3TC, and you can see it's a green light among all of these guidelines for DTG and 3TC to be a preferred or recommended regimen. I want to close by just noting some comments that were issued by the Food and Drug Administration and by the European Medicines Association when the 2-drug regimen was approved. First, from the US FDA. Currently, the standard of care for patients who've never been treated is a 3-drug regimen. With this approval of the 2-drug regimen for initiation of therapy, patients now have the option of taking a 2-drug regimen in a single tablet, eliminating additional toxicity and potential drug interactions from a 3rd drug. Having a drug-sparing treatment available that uses fewer drugs is beneficial to patients who may have issues taking multiple medications over a long period of time. And from the EMA, present antiretroviral therapy is a lifelong treatment, and for the last 2 decades has consisted of triple therapy. 3 agents have been combined in order to create a sufficient barrier to resistance. Boosted PIs and 2nd-generation integrase inhibitors, dolutegravir, bictegravir, are agents with a high resistance barrier, and whether the addition of 2 NRTIs is not necessarily needed. Finally, reducing lifelong therapy by 1 agent without a negative impact on efficacy and the risk of resistance development is naturally warranted. No agents can be considered fully free from side effects, seen daily or potentially after long-term therapy. 3TC, added to dolutegravir in this fixed-dose regimen, is considered to have a quite favorable safety profile without long-term known toxicities, even though it's been used for more than 20 years. So in conclusion, there have been over 1,400 patients in the phase 3 trial in treatment-naive therapy, over 740 patients in the switch therapy clinical trial, and more than 2,000 patients studied in real-world effectiveness studies. And the data from these trials have answered many of the key questions seen here, such as durability, high viral load populations. What about blips or low-level viremia? What about the speed with which virologic suppression is obtained? Is the high barrier to resistance continued even with 2 drugs? And do they get in the guidelines? And I would say the answers to these are quite convincingly yes in all instances. So in summary, the last slide, is 2-drug antiretroviral therapy a good option for people living with HIV? Well, we've talked about the clinical trials data, both switch and treatment naive, which I think convincingly state that yes, it is a good option. We also have real-world evidence, which is building, consisting of more than 2,000 people living with HIV as of the early part of this year and continuing to grow as more real-world data is presented and published. And these data confirm the results of the clinical trials in these real-world settings. Among the small number of people in these trials who have experienced virologic failure, no one with confirmed virologic withdrawal has had resistance. And in the 3 years of follow-up in Gemini, the 1 patient, which I described for you, out of over 700 followed for 3+ years, has developed resistance to 3TC and dolutegravir. We think it is an excellent, well-tolerated, highly efficacious combination, which allows for treatment with a minimal potential for drug-drug interactions. Well, I thank you very much. It's been my great pleasure today to share this with you, and I'm happy to answer any questions you might have. I'll see if I can stop the sharing here and get back to the main group.
Thank you, Dr. Hicks, for such a wonderful presentation. We have a couple questions from the audience. One question from Chile. One doctor is asking if you will use Dovato or dolutegravir in a patient that has recovered for acute pancreatitis.
So the question is, a person with acute pancreatitis, is it safe to use dolutegravir 3TC as a treatment regimen?
Yes.
I am not aware of any specific data that has looked at this question in people who have suffered an attack of pancreatitis. We do know that some of our older drugs were associated with a higher risk for pancreatitis, for example, didanosine, and way back when a drug called Hivid were sometimes associated with pancreatitis, but those drugs are really not used any longer. I would say that in the absence of data, a rational idea to treat someone with drugs for which there is limited data on the incidence of pancreatitis with them, but for which I am not aware of any warnings associated with pancreatitis that exist for that combination. I think it would be a reasonable choice, but obviously very close follow-up would be essential.
Perfect. And another question, do you see a role of basal genotyping for patients naive before starting Dovato, and also a role for proviral DNA genotyping before switch to Dovato?
Yes, what a good question. So the issue of genotyping prior to initiation of therapy is an increasingly important one. And the prescribing instructions for dolutegravir 3TC indicate that it is not indicated for persons who have known resistance to either of the components, lamivudine or dolutegravir. Now, as far as I know, there are no places in which dolutegravir resistance in treatment-naive patients exists in any significant numbers. So I would have less concern there. In studies done in the US in large populations of treatment-naive patients, the prevalence of M184V, or resistance to lamivudine, is about 1 to perhaps 2%. So 1 or 2 persons out of 100 might have M184V because it was transmitted resistance to them. So in that setting, if I knew that M184V was present, I might not want to use just dolutegravir 3TC. Having said that, in our data and in real-world study data using DNA resistance testing, archive resistance testing, we have identified a modest number of persons with clearly historical acquisition of M184V. And they have responded equally well to those who did not have M184V in their prior resistance testing. So probably the presence of M184V is a factor, but if you don't have access to resistance testing, I personally would still feel comfortable using dolutegravir 3TC, even though the prescribing information suggests that if resistance testing is available and if M184V is identified, then that is a situation where a 3-drug regimen is probably warranted.
Thank you. And we have one last question.
Sure.
We're just running out of time. Who would you say is the ideal patient for Dovato use?
Yes, well, this will be my opinion.
Yes.
And I can tell you that the company may have we saw that very fancy commercial at the beginning, and it's really great and exciting. In my opinion, the data of the Tango study, the switch study, which now we have 2 years of follow-up with zero persons with treatment failure, zero. Over 350 patients, not a single one with treatment failure, tells me that if I were seeing and treating patients, I no longer have an active clinic, I would want to think about switch patients as my primary way of employing Dovato. I think it's fine for start, but I think you have to be anxious about hepatitis B, perhaps a M184V, we've shown that you can do it, but you need to be very attentive to patient follow-up and making sure the laboratory data is seen and that you can adjust the therapy if needed. So I think treatment-naive patients, absolutely fine. But for me, as a practitioner, after someone is suppressed, 3 months, 6 months, I would ask, why would I want to continue 3 drugs for 5 years, 10 years, 20 years, when there's strong evidence that they're going to do great on just 2 drugs? So my practice would be, at the end of 6 months, I would look at all my patients and say, which ones cannot go to 2-drug therapy, and I would put everybody else on Dovato, lamivudine.
Thank you, Dr. Hicks.
Okay.
Thank you.
That's just me, though.
Yeah, I know. That was the idea, to get to know your opinion.
Sure.
So I'm going to switch to Spanish to close. So
Yes,
thank
of course.
you very much.
Thank you so much.
Quería aprovechar de agradecer a todos quienes nos acompañaron en
I wanted to thank all of you who participated in this symposium by Dr. Charles Hicks. The questions were answered in the measure that they were arriving. So we would like to give a very big round of applause for Dr. Hicks and thank him for his lecture. And now we will listen to Dr. Carlos Beltran, who will tell us how the course will proceed. Good night, Dr. Hicks.
Bye. Thank you so much.
My pleasure. Bueno, terminamos el primer bloque. Vamos a hacer
We are finishing the first block and we will have a small break, 10 minutes, and continue with the second symposium for the day.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de 2 drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir, alafenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.
El compromiso de Gilead por una eventual erradicación del VIH ha sido firme. Hemos seguido progresando constantemente con medicamentos efectivos que se han vuelto progresivamente más simples de tomar, más fáciles de tolerar y más seguros a largo plazo.
Es un anticuerpo
El VIH se ha convertido en una enfermedad crónica tratable. En América Latina, cada vez más y más pacientes tienen acceso a nuestras terapias innovadoras que salvan vidas y mejoran su calidad de vida. Nuestro compromiso es permanente y aún queda un largo camino por recorrer, pero está en nuestras manos triunfar. Debemos continuar trabajando y hacer posible, y no solo lograr que nuestros pacientes sean indetectables, sino también a un estado de salud y bienestar integral.
Bien, buenas tardes. Proseguimos entonces con la segunda parte de la jornada del día de hoy. Es un honor, un privilegio y por supuesto un gusto presentarles al doctor Pablo Parenti, especialista en medicina interna, doctor en medicina, médico docente e investigador de la unidad de retrovirus del Hospital Centenario de la Facultad de Ciencias Médicas de la Universidad Nacional de Rosario, Argentina. El doctor Parenti no solo es eso, sino que es un gran amigo y uno de los pioneros del grupo latinoamericano, incansable, siempre lleno de inquietudes y por lo mismo es un gusto, Pablo, aunque sea a la distancia, saludarte y dejarte a cargo del siguiente bloque.
Bueno, buenas tardes. Muchas gracias, Carlos, por la presentación y bienvenidos a la segunda jornada del tercer Congreso de Improving Standard in HIV Care. Y para presentarles en esta segunda parte el simposio sobre el futuro inmediato. Me es muy grato presentarles a tres destacados presentadores y expositores. Vamos a empezar con la primera presentación, son 20 minutos cada uno y luego tendremos 10 minutos para las preguntas. Bueno, en cuanto a la primera presentación, tenemos la presentación que se llama Menos es más, menos drogas, menores niveles plasmáticos. Está a cargo del doctor Luis Mosqueda. Él es director del Hospital Regional de Alta Especialidades del Bajío, México. Su último encargo fue como director del Centro de Atención Ambulatoria de Enfermedades de Transmisión Sexual en León, reconocido infectólogo cuya participación para el control de las epidemias de dengue e influenza que hubo en Guanajuato fue muy importante. Tiene especialidad en medicina interna e infectología y maestría en investigación clínica. Es miembro del Sistema Nacional de Investigaciones y profesor del Departamento de Medicina y Nutrición de la Universidad de Guanajuato. Así que sin más, los dejo con el doctor Luis Mosqueda en la presentación Menos es más, menos drogas, menores niveles plasmáticos. Bienvenidos.
¿Qué tal? Buenas tardes.
Hello, good afternoon.
Sí, buenas tardes. Espero que ya me estén
Good afternoon. I hope you can hear me properly. I hope you see my screen. Could you confirm that you're listening to me? Yes, Luis. Everything is fine. Thank you very much, Pablo, for the presentation. And I would like to thank you for the opportunity to share with my colleagues who, besides being specialists, are friends. And we have been working on HIV. I was asked to speak about this topic. Less is more. Less drugs, less plasma levels. And there will be many presentations of changes that we see in the near future as far as what we have done on HIV treatment. Paradigms have started to shift. We have lived with some paradigms, and I think, well, I would like to start with this story that you have heard on how a paradigm is born. This is the story of a group of scientists that put in a cage 5 monkeys. In one of the corners, they put a ladder whereby they could reach bananas the monkeys want to reach the banana, but one of the monkeys goes up. The other monkeys are bathed with cold water, so they want to go up for the banana. And since cold water falls onto them, they don't want anybody to go up. But the most interesting thing is that at a certain point, scientists decided to replace one of the monkeys and put a new one. And the new one sees the bananas, tries to go up to get the banana. As soon as it tries, the other ones receive the water, and it doesn't understand what's going on. But all of them stop him. The interesting thing is when they replace another one, another monkey, the newcomer that goes to the cage tries to get the bananas. He is stopped, but now the one that has never been wet doesn't know what happens, but participates and starts to stop the one that wants to climb the ladder. They keep replacing the original monkeys at a certain point. There are monkeys that have never been wet by cold water, but nobody goes up to get the bananas. They know that somehow it is forbidden to get the bananas. If anyone tries, the others will hit him. And they never knew why. This is a paradigm. It is forbidden to get the bananas. Everybody follows the rules and nobody knows why. And then it is so difficult when paradigms are born, so difficult to change them. And it is very important because this is one of the big ones. When we see this idea of using 2 instead of 3 medications, we are going against the paradigm. Some say, how can we do that? 3 must be used, and it is a fact. It's an undisputable fact. We have to use 3. And suddenly, we don't know where we started, but we are discussing and trying to say that it has to be 3. Now that we see so many single tablet regimens, and now we see those with 2 drugs, we try to reserve them. We have our limits to use them because we are not totally convinced that it is a good idea to use them because we believe that they have to be 3. But why 3? Very briefly. One day in 1997, this is the first publication of a drug for HIV that was effective, AZT. It worked, but not so much. Then in 1990, we had DTC that worked, but not so much. Viral load goes down. There are so many failures, but some said if AZT works, why not we put both together? And they put them both together, and they saw that they both work better than one. And they said, look, it is a good idea to mix things. The most interesting thing is that lentinavir appears. Someone said, oh, let's put together AZT, DDC, and lentinavir. And so we have heart that we all know, the combination of 3 medications. And then we all say that we have to give 3. But if you realize, we have insisted that it has to be 2 nucleosides. But why 2 nucleosides? Is not because there is a scientific reason. It is because they were the first 2 ones that appear. If lentinavir would be the second one,
y probablemente habría funcionado mucho mejor que 2 nucleósidos. Pero la historia se dio así y accedimos a que debemos forzosamente usar 3.
Made it this way. We had to start using 3, so now it's hard for us to accept 2 drug therapies. But all of these studies, Gemini 1 and 2, comparing the 2 drug regimen with 3 drug regimen, we see that both work the same. And some people say maybe it's a short follow-up and it will fail. but they continued working well after 48 weeks, after 72 weeks, after 96 weeks, and we still say it seems to work, but using 2 drugs is strange. So let's continue with 3. We are not able to surpass the paradigm of the 3 drug regimens. Not only with this combination, we have also seen this with the boosted protease inhibitors born from the Calitra type therapies. In this meta-analysis of 3 randomized trials using 2 drug therapies that are boosted, it is shown that 2 versus 3 drugs works quite well. But when we think about using one of these strategies as the first choice, we are not quite convinced. Why? Because it's better to use 3. There's something that stayed with us from this idea, this historical idea. Once again, we see in SWORD 1 and 2 and switching studies where you change patients from a 3-drug regimen to a 2-drug regimen, we see a follow-up. There's no statistically significant difference between the 2 regimens, but we still believe that the 3-drug regimen is better. Once again, we see another study, dolutegravir plus 3-TC, compared with a 3-drug regimen, including TAF. Once again, both groups were quite well. They show similar results. And sometimes we start thinking of certain types of ideas. We think that is the 2-drug regimen is not as potent. It will not cause similar viral decay rates, but viral decay rates are practically equivalent. There is no difference. However, people say they make more mutations. These patients will fail more, and this has not been shown. We will have more blips. We will have a viral release in a periodical manner. And this has been searched for and it hasn't been demonstrated. No blips have not been demonstrated or failures have not been demonstrated. So every question we ask hasn't occurred, but we still don't feel comfortable with using 2 drugs because we have our 3-drug paradigm, and it has been very hard to move us from that paradigm. I think that in some way we must adapt to our practice this new scientific information, because when we use 2 drugs compared with 3 drugs, it is less costly, more tolerable, with lower toxicity. We have several benefits, but it's difficult to adopt these practices because of the paradigm, and we should little by little break this paradigm. Well, is this true drug regimen for everyone? Not really. What about the rapid start therapy? I think it could be used. Some people say yes, but others say that sometimes you start with high viral loads, and we may question about starting with a 2-drug regimen. What happens if we have an opportunistic infection such as TB or hepatitis B co-infection, where we would prefer 2 nucleosides with activity against hepatitis B? Here we may state some exceptions, but if we do not consider these exceptions, any of the rest of the patients could be favored by the 2-drug regimen, and several studies have shown that this is so, both for switching and for other cases. I don't know what more evidence we may show for the usefulness of the 2-drug regimen compared to the 3-drug regimen. In spite of this, it has been hard for physicians to adopt to this change in paradigm. speaking about lower doses, we, as occurred with the mentioned paradigm, we have seen some changes regarding lower dosages. In our countries, until recent times, we still work with regimens using efavirenz as a third component. Our schemes use 600 milligrams efavirenz. For younger people here present, it is obvious that when you use efavirenz, this is 600 milligrams. In general, now it comes as a single tablet with emtricitabine, with lamivudine, but this was not always so. Those of us who are older and working in this topic, efavirenz used to come in a separate tablet, and using 200 milligram tablets, we use 3 tablets to complete the 600 milligrams. Here we show results for the dose-defining studies for efavirenz. We see the number of patients reaching undetectability when comparing the different dosages, 200, 400, and 600 milligrams. We see no differences in the rate of undetectable patients. For some reason, we have sticked with 600 milligrams in spite of lack of difference in effectiveness. Although there is more toxicity, especially in the central nervous system, with 600 milligrams. In spite of all of this, we currently use 600 milligrams. So we have assumed that we must use efavirenz 600 milligrams. The group from Australia, the David Cooper group, used this hypothesis. They considered that if the original studies, the results were very similar for 200, 400, and 600 milligrams, they compared combinations of efavirenz of 400 and 600 milligrams and showed that viral control was practically the same. 400 milligrams worked as well as 600 milligrams with a small detail. Those using 400 milligrams show lower toxicity, as we knew from the original studies, phase 2 studies in development of efavirenz. So we learned from this Australian study that efavirenz 400 milligrams is non-inferior to efavirenz 600 milligrams. This is not recommended in pregnancy because we would have to show that we reach the correct dose, and we should avoid this when concomitantly treating with rifampin, because rifampin decreases doses of efavirenz. And I go back in history where it was described that efavirenz 200 milligrams was used in 3 tablets, but when using TB treatment, the recommendation was to use efavirenz 800 milligrams to compensate the drop in plasma concentrations due to the use of rifampin. Today, we do not perform that adjustment. We use 400 milligrams even when combining with anti-TB drugs. We now understand the origin of this dosage. We may use 600 milligrams when using anti-tuberculosis treatment to avoid the drop in plasma concentrations. Why is it good to use less dose? Less adverse events, less cost? It is very important. An interruption just to tell you that you have 2 minutes more for presentation. Well, yes, I will close now. Tenofovir has been another drug that has been with us for a while. We always assumed that the problem with tenofovir was that it was absorbed in the gastrointestinal tract when accompanied by disoproxil, and we had to tolerate that part of tenofovir stayed in plasma, blood plasma, and only part went into the lymphocyte. The part that went to the blood plasma could cause renal toxicity. We now have TAF with alafenamide. Practically all of tenofovir goes in the lymphocyte. Very little stays in plasma. Very little has to be eliminated by the kidney, causing less toxicity. And so now we see that 25 milligrams TAF is as potent as 300 milligrams TDF, accompanied by less renal toxicity and less bone toxicity. So what to conclude with all of this information? I think in first place, it is very difficult to make a paradigm change, but we must try. The close future shows us scenarios that consider optimization of antiretroviral strategies. And we must remember that the objective is not only viral control, but we must also consider tolerability, simplicity, adverse events, costs, and posology. Thank you very much.
Hola, bueno, agradecerle a Luis por tan interesante presentación.
Thank you, Luis, for this very interesting presentation. And thank you for complying with the 20 minutes. We now go to the second presentation, The Road Ahead of Us, Prolonged Action Drugs, by another colleague from the Latin American HIV workshop, Dr. Alejandro Afani, internist, immunologist, professor from Universidad de Chile, director from the HIV Center of the Clinical Hospital of the university, founder of the Latin American workshop in HIV, and member of the committee of the Health Ministry HIV guidelines. Also publisher of the HIV book, ex-president of the Chilean Society of Immunology, member of the European Society of HIV/AIDS, and co-author of the Latin American Guidelines for HIV treatment. Now I leave to you, without further ado, Dr. Alejandro Afani, The Road Ahead of Us, Prolonged Duration Drugs.
Thank you very much. Thanks for sharing with you, with Liz, Ernesto, and the rest of the members of the Latin American workshop. We would have loved to be there in person, but that's the situation. But I'm very happy to be here with you. It made a lot of sense what Luis just said regarding paradigms. The monkeys and the bananas. It is also valid for what I'm going to tell you, which is the road ahead and these long-acting drugs. If we take a look back, the road we have traveled, there was a very long period of time for development of antiretrovirals, Sidovudin in 1987, 2-drug therapy, 3-drug therapy, but now we have advanced in efficacy, adherence, convenience, safety, tolerability, and the latest drugs approved in the last 2 years are bictegravir, integrase inhibitor, doravirine, a non-nucleoside also approved, and ibalizumab, the first one of monoclonal humanized monoclonal antibodies in the patients non-naive. Why this idea to move forward? I agree that it is very difficult to shift paradigms, but we have to understand that ART, triple therapy, is not carved in stone, and we have to move forward. I am convinced that we are experiencing the last phase of triple therapy because of all of the new things that are coming in the short and midterm. We know that antiretroviral therapy can make the patient become chronic, but this requires the patient to continue taking continuously antiretroviral therapy. And there lies the challenge of adherence and convenience that can affect success and lead to virologic failure. This is an important element to consider in terms of having long-acting drugs. There are some approved and others under development. Those that have been approved, we have rilpivirine and an RTI with a long-acting cabotegravir. This switch therapy has been approved in Canada, but it will be approved soon by the FDA, probably in 2021. Ibalizumab, as I said, a monoclonal antibody, humanized, that is given IV for multi-experimented patients. And then we have islatravir from a different family. It's an inhibitor of the translocation of reverse transcriptase. And another one that is very potent is capsid inhibitor, GS6207, subcutaneously, lenacapavir. To summarize, we have cabotegravir, rilpivirine, and an RTI, islatravir, humanized monoclonal antibodies, the first one, ibalizumab, and lenacapavir. But there are still questions that come up. What we are saying, can we move away from daily oral therapy to carry forward this therapy? Are these therapies as effective? What happens with toxicities, resistance? Let's see what we can say. In terms of ibalizumab, Trogarzo, in 2018, it was approved for multi-drug patients. It attaches to the CD4 molecule in the second region of CD4.
Fostemsavir, pero de ese no voy a hablar, no es un...
Fostemsavir,
el estudio
this is the study that supported the use of ibalizumab. These were patients pre-treated with a viral load of more than 1,000 copies, and they had 53% of resistance to all of the drugs, 68% with integrase resistance. A loading dose was given, IV, day 7, and then maintenance dose. The interesting thing was that in those patients, 83% presented an increase or reduction of 0.5 log on day 14 versus 3% in the control group, which was statistically significant, and 60% presented a reduction of more than 1 log. Therefore, it was rapidly approved by the FDA. Cabotegravir, nanosuspension, these are nanocrystals, just like rilpivirine. They are both given separately. They have a very long action, which allowed to conduct studies on a monthly basis or every 2 months. It has been extensively studied for treatment, but there are also advances in PrEP. I'm not going to speak about that now. Regarding cabotegravir, rilpivirine, this was the first study, and it was very long. As Luis said, a lot of follow-up is required, and to be convinced to obtain the approval of the FDA that these therapies are equal or better than the triple therapies we have. This study was a very long follow-up. Patients over 18 years old, viral load over 1,000 copies, more than 200 CD4. There was an oral induction of cabotegravir with abacavir 3TC, and then they divide into 3 arms. Administration every 3 months, every month, compared to oral therapy. This was presented in Glasgow 2018. It was published in Lancet 2017, and the efficacies were 94, 95, 91% with very low rates of discontinuation. The best outcomes at week 160 happened in the administration every 8 weeks or every 2 months. And even more recently, we have those two other, Atlas and FLAIR. Atlas study for patients that were non-naive and FLAIR in naive patients. The first one is with a large N, and the truth is that those patients that had two non-nucleoside integrase inhibitors went through an oral phase of cabotegravir rilpivirine for 4 weeks, and then they've continued with the cabo-rilpi once a month versus maintain the background therapy. And then an extension phase, Atlas 2M, that I will tell you about later. And FLAIR study, naive patients, first triple therapy, dolutegravir, abacavir, 3TC. Then they continued just the same. And the one that went to cabotegravir rilpivirine, cabotegravir orally first. Both studies analyzed together show an efficacy of 93, 94% with very low rates of virologic failure without development of resistance. And in the extension period of Atlas, that is called Atlas 2M, the purpose was to study once a month versus 2 months. And the oral arm was given oral induction with cabotegravir rilpivirine to standardize, and then continue the study. In Atlas 2M, there was 94, 93% of efficacy, 48 weeks, very low rates of virologic failure. In the satisfaction questionnaires, 98, 94% in favor of injectable therapies, especially every 8 weeks. The pharmacokinetic analysis of those that had discontinued showed that rilpivirine and cabotegravir levels persisted for more than 1 year. FLAIR, OLI, which was done later. Remember that this study compared oral therapy, dolutegravir ABC 3TC, with the intramuscular injection once a month after oral therapy. Here they saw whether it was necessary or not, or know how necessary oral induction is with cabotegravir rilpivirine. So they did this OLI or DTI. At 96 weeks, you see levels of efficacy 86, 89%. And in FLAIR OLI, 99, 93% in the direct arm versus the OLI arm that used cabotegravir. So it seems that you could go straight to the injection phase. There were very low rates of virologic failure, less than 1%. And those were 3 cases in Atlas and 3 in FLAIR. Adverse events, 99% were grade 1 and 2 and associated to the site of injection. But this, they didn't result in discontinuation of treatment. Safety was demonstrated in week 48, comparing LA intramuscular versus oral. They were comparable. There was no difference between them. It is interesting to say that cabotegravir rilpivirine therapy is compatible with the other studies in triple therapy, dolutegravir and even viltegravir. So this therapy can be installed as a safe and effective therapy approved by the FDA. We will have it in 2021 to be used. Very quickly, I'm going to speak about islatravir. Well, Dr. Martinez will speak about that, but islatravir is a new nucleoside with a unique mechanism of action that is very potent. This drug, just like the other nucleoside analogs, has to go into the cell, and by action of the cell kinases, it has a very long half-life, between 78 and 128 hours. There is a very slow disassembly. It has a dual mechanism of action. It's a chain termination role and also has a translocation inhibition role. So you can see different strains with multiple mutations, even TAM mutations, K65R. They have a very important, they're very potent, 100 times more potent than AZT, 1,000 times more potent than 3TC. Doraviri, which is a non-nucleoside, also new, very potent, has kinetic or pharmacokinetic characteristics which allowed to associate it. This is the second dual therapy that is moving forward very quickly with very good results in the studies that have been shown lately. This is the initial study, phase 2B in ES 2019, where the dose is decided. And it works perfectly well with more or less than 100,000 copies, regardless of the CD4 count. Today, islatravir doradavir study is advancing in 3 important studies: patients that are multi-resistant, patients in switch, and naive patients. And also because of the pharmacokinetic characteristics, they are doing studies in PrEP with implants, a very interesting therapy that is also moving forward. And finally, lenacapavir, which is a new capsid inhibitor. It also acts at different stages of the cycle, which is very interesting because it seems that those drugs... I can't hear now, yes? I was saying that no, there is no problem. We can hear very well. Just a couple of minutes are left. This is the last drug. And lenacapavir has a mechanism of action that acts by inhibiting the disassembly of the capsid and nuclear transport, virus production. So picomolar doses of lenacapavir have a very high power. This became evident in the preliminary pharmacokinetic studies with an initial dose, oral dose, and followed by the subcutaneous dose. Simulations are being made in phase 2-3 with an oral loading dose and followed by maintenance dose every 6 months. A very interesting study that is moving forward, and we will probably have some news very soon. And this is what's coming in the future. We said that ivelisumab was the first one, but an important number of new monoclonal antibodies are coming of broad spectrum, acting at different points. There are still challenges. These are interesting challenges. Maybe COVID vaccine implementation logistics is going to help to understand the logistics for the management of those injections, of those drugs once a month, once every 2 months. And I finished with these slides to tell you that in the timeline from the discovery of the virus in 1993, much has gone by. The era of the integrases were still here. But since 2020, we are moving into the 2-drug regimens, and the long-acting ones, and in the future, implants and humanized monoclonal antibodies. Thank you very much.
Bueno, Alejandro, agradecerte nuevamente tan excelente exposición.
Thank you,
Gracias.
Alejandro, for your excellent lecture. And thank you for using your 20 minutes. And we have now our third and last lecture with the title, New Drugs Around the Corner. What happens in Latin America? Also by another colleague from the workshop, Ernesto Martinez from Universidad del Valle, Cali, Colombia, who has received training in the Jackson Memorial Hospital in Miami and then completed a 2-year residency in infectious diseases in the University of Cincinnati. He is a professor in the Department of Internal Medicine and in the University Hospital of del Valle in the unit of infectious diseases and infection control. He currently presides the Committee of HIV/AIDS in CIM and is a co-president of the guidelines of Colombia for the Ministry of Health. Welcome, Ernesto, and please begin your lecture. Thank you, Pablo. Good afternoon. Good evening to everyone. We will proceed now with something that is less futuristic, centered around our reality, and the interventions by the previous speakers have made my task easier. We will speak about new agents around the corner, especially for Latin America. You probably know this graph. This is the FDA approval for HIV medicines throughout the years, and I will highlight those I will speak about in my lecture. We have spoken about Doravirine, combined or not with Tenofovir and Limavudine, Dovato, which was mentioned. Why all these drugs? First of all, these are the ones that we still do not have, but those that, in combination with dolutegravir, have been recently more studied and shown to have high clinical efficacy. Some of them have innovative mechanisms or innovative combinations, so it's worthwhile to review their use in our region. These are also agents that are being included strongly in international guidelines, as Dr. Hicks mentioned. Here we have bictegravir, TAF, FTC, dolutegravir, lamivudine, present in the most important reference guidelines. Now, speaking concretely, let's start with elvitegravir, cobicistat, TAF, FTC, called Henvoya, approved in 2015 by the FDA. In Latin America, its use is only present in Colombia and Argentina. It has been approved only there. In other countries, Henvoya was not considered because they have Vitarvid. Henvoya has shown its efficacy. This is one of the most solid data with 144 weeks follow-up, comparing it with its brother or sibling using TDF when considering recovery of CD4. It favored Henvoya. These naive patients showed fewer adverse events, both renal and bone related. Now, considering change in treatment or switching, those patients coming from other schemes After the observation period, it was shown that in week 96, the switching to Genvoya was statistically superior. Two pivotal studies showed an efficacy that was superior for Genvoya, very solid results. Genvoya, when having TAF, we expect the profile to be better, and the slide shows that patients that were switched to Genvoya had a greater proportion in better bone mineral density studies and lower excretion of urinary markers for renal toxicity. We also know for many years that it does very well in women. This is also a switching study where women were changed to ARTV, RTV, FTC, TDF, and efficacy is quite good after 46 weeks, with benefits in women, especially in older women that were quite notorious, as you can see in these graphs. But one of the things that caused a lot of impact is how the combination of tenofovir, cobicistat, abitagravir is favorable with patients with renal impairment, especially terminal, those using hemodialysis. Thanks to this study, it was established that efficacy and safety was such that it could be used as one tablet a day in this particular population, and it was approved by the FDA without important accumulation of metabolites or active drugs, except for emtricitabine, which does not represent much of a risk. Biktarvy is probably the compound that has received more attention in the last years. It's the first treatment based on INSTI that are not boosted and approved and then used currently in Mexico, Argentina, Brazil, and Chile. The most important studies are those that you see in this graph, two in naive patients. Another was a switching, all of them comparing with a close sibling, dolutegravir with abacavir, lamivudine, or FTC and TAF. When we put all these results together, we see that the global efficacy of the three schemes in the two different studies is practically identical. The virologic response is absolutely equivalent, showing non-inferiority in all of these combinations. And this is also seen with viral loads over 100,000, no significant differences. Here we also see in the graph at the right that when we switch to Biktarvy, we see the maintenance of virologic response with very few virologic failures in these patients. There are other experiences about switching in patients coming from protease inhibitors in women with different schemes and also in pediatrics. All of these experiences show that the switching to Biktarvy, tenofovir, emtricitabine is a good recommendation. It's quite beneficial with maintenance of viral suppression that is high and with a good results in terms of renal metabolism or renal results and bone mineral density. Now, Dovato, just to say that it is approved and used in Argentina, Chile, and Uruguay, and soon, we don't know what soon means with the pandemic, in Colombia, Mexico, and Brazil. And this is from BIV, Glaxo, shown also by Dr. Higgs. The efficacy of dual therapy at 144 weeks was the same as the triple therapy, as Dr. Mosqueda also mentioned, and allowing to change the paradigm, as Dr. Mosqueda mentioned, and patients under 200, the results for CD4 were not significantly different. This is a switching study, Tango, where there was a good virologic efficacy. The second outcome was favorable for dolutegravir lamivudine. So we can say that this was non-inferior and quite adequate as switching therapy. Doravirine is a non-nuke, new generation. It comes alone. In our countries, we will probably see it in combination with the TDF3TC, quite potent with wild type. Here, the EC50 with a very low EC50, and in the presence of several mutations that emerge in case of virologic failure, such as 103, 181, and 181C. Doravirine keeps its efficacy, so it could be useful when having virologic failure. What we have until now is a first-line study that drive ahead, comparing with efavirenz in a single tablet, where we see non-inferiority after 48 weeks. But we do see an improvement in terms of the tolerability and toxicity profile of efavirenz with less neuropsychiatric side effects and an improved metabolic profile. We also have the drive forward. And after 96 weeks, we see almost a statistically significant difference in favor of the darunavir-based schemes. And it also brings advantages in the safety profile and the metabolic profile. Very interesting, the studies about switching. In our region, in many countries, this is probably the best use that we can give to doravirine. Here we have the drive shift study presented this year in several congresses. We see that we have an immediate switching scheme and a late switching scheme or delayed switching scheme. With any of the two, after 144 weeks, we pass from 90.8 in the immediate change to 94.6 in the delayed change, to 80 and 84% respectively for 3 years of follow-up, which is what we observe in most switching studies. With the fact that in those that did not comply with the virologic objective, there was no resistance. As Alejandro mentioned, there is lots of interest with this combination with islatravir, an inhibitor of transcription and translocation. After 6 months, we remove lamivudine and we only give it the two initial compounds with several schemes, because these are phase 2B studies, the PO11, and finally we observed that 2 of the 3 doses used result to be quite effective in the ranges that we like to see, over 90%. In those patients presenting virological failure or who do not comply suppression at 6 months, in the AIDS 2020, it is reported that viral load will be very low. This also explains why there is no resistance to these compounds, and it's very easy to rescue them with alternate schemes. This scheme also has metabolic advantages. At the level of glucose metabolism, there is no statistically significant differences with the reference scheme, doravirine, 3TC, TDF, and all the schemes have a trend to improvement in the lipid profile. For our region, we are receiving this combination of darunavir, cobicistat, including TAF-FTC, as a single tablet. It has been approved in Brazil, Chile, and Argentina, and possibly in Mexico for 2022. For the first 48 weeks, This had an efficacy of 91.4% compared to 88.4% in the Hamburg study, which compared the compound based in TAF and compared to TDF. And in these two darker columns to the right, we see that this efficacy is kept as 85 to 83%, showing that there is no statistically significant difference, no criteria for inferiority. And we see, as occurs with TAF, good profiles for renal function with good glomerular filtration rate with creatinine or cystatin. This is a study reported last year, Diamond study. It's not a comparative study, unfortunately. 109 patients with doravirine, cobicistat, tenofovir, TAF. There were no differences in independent of viral load and CD4s, global response in red. Here is the objective of a viral load under 50, and in the rest of the graphs, between the observed and the FDA snapshot, we have the same responses, be it with high or low CD4s, high or low viral loads. So this is useful for immediate treatment as well. And we have here the Emerald study, a switching study of patients using boosted protease inhibitors. And here we have the evidence reported last year, 96 weeks, maintaining excellent viral suppression for this switching therapy, over 90%, with very few virologic failures. So it's a very attractive compound that will be present in a few countries. And I want to summarize what I have mentioned with this table, saying that all of the schemes that we have discussed, I didn't want to stop regarding dolutegravir rilpivirine, because it is not in the plans of the pharmaceutical industries to bring it to Latin America or Central America. So I just use it as a reference, but only for switching therapy. There is no space for this therapy as a starting therapy. The rest of the therapies, I have shown you that the rest of the options have very favorable evidence used as first treatment or switching treatment, where elvitegravir, cobicistat, TAF, and FDC shows efficacy, bone and renal safety used in terminal renal failure, but not in pregnancy or with rifampin. Bictegravir, TAF, FDC, very good in terms of efficacy, cardiovascular, renal, and bone safety. It can be used in women and in terminal renal failure, but it shouldn't be used with rifampin, and we still don't know much about pregnancy. Everything goes fine until now, but data are few. Dolutegravir lamivudine, we know that there is no experience in patients with TB using rifampin, no experience in pregnancy. Advanced AIDS, we had the problem of a viral load. It may work, but we need more evidence. We understand that its use must be based on studies, and it's okay to switch with a previous M184V. Problems not to use as initial therapy in patients with prior M184V. Darunavir, cobicistat, TAF, FDC, good efficacy, very useful in those patients that present late with good cardiovascular, renal, and bone and not used in rifampin or pregnancy. Doravirine, TDF, 3TC, We have proof of its efficacy. However, it seems that it's inferior to integrase inhibitors, but this can only be assumed because there are no comparative head-to-head studies. This is a combination with a good safety profile, a good resistance profile, not to be used with rifampin, and no experience in pregnancy. I want to remind you here in what countries these drugs have been approved. As you can see, out of the Latin American and Central America region, penetration has been little, in spite of having been approved for at least 5 years by the FDA. This is the summary I can give. They are all excellent options that may be used as late introductions. In the same countries, it is described that access has been difficult, comparing private and public health. And because of this, the impact is low in the guidelines for these countries. And I leave you with that reflection. Thank you very much. Thank you, Ernesto. Excellent presentation. Without further ado, we now open the Q&A for 10 minutes.
Now I'm going to ask you the questions made by the participants, whom I thank for their interest. First question, Tatiana Drummond. For Luis, children usually have a viral load over 500,000 copies. So children wouldn't be candidates to use 2 drugs. What is your opinion? Yeah, and I mentioned that, Ernesto. I think that the limitation, although it hasn't been demonstrated in advanced disease with less than 200 CD4, the 2 drugs shouldn't be used, but with more than 500,000, yes. Or the other option, since it is approved for initiation or switch, you start with 3, it is undetectable, and then you use 2. That would be a very good transition. Thank you, Luis. A second question for you. By Cristian Pedro Resurrección. Do you recommend to start 2 antiretrovirals just from the start, or after finding undetectability, you think about switching to 2 antiretrovirals? That all depends on what you're going to use. There is evidence of initiation with dolutegravir 3-TC, but not dolutegravir rilpivirine. Dolutegravir rilpivirine, only clinical trials in switch have been made. But in this idea of shifting paradigms, we want to move forwards and lose fear. Maybe we should start with switch, and then we can go to the initiation. Maybe that's the best way we can move forward. Thank you, Luis. If you allow me, I would like to ask a question to Alejandro. I would like to know, in your experience as researcher, and if there are data, I think they do exist, on the acceptability of the intramuscular injection of long-acting drugs, not only the adverse events that are few, because going from a pill to an injection, in principle, might seem to be a problem. Is that so? Very interesting. In the LATE-2 study, there was an acceptability survey, and also in Atlas-2M, there was one also. The acceptability is directly proportional to the time. The greatest acceptability is every 8 weeks. For example, in the 2M study, patients came from oral therapy that went straight to once every 8 weeks, and others every 4 went to 8 weeks. But in all of them, without exception, 94, 98, and 94% accepted receiving the therapy more spaced out. So this will be accepted by the patients. There are some logistic issues, but as we move forward, because I also said that new strategies are coming every 6 months with the same outcomes, probably maybe I think this here to stay. Maybe it's not the panacea, it's not for everyone, but I think this will be used little by little. And patients are asking about it. Patients are asking about injectable therapies. Thank you, Alejandro. Maybe it is what Luis said. Maybe this is a prejudice we have to do away with. We think those are barriers, but maybe they do not exist. Thank you. I have one question for Ernesto from Laura Bahamondes. Why in Del Trigo there was co-formulation with lamivudine and not emtricitabine? Very good question. When we started to see information about this, this was the first question we asked. At that time, the answer given by the pharmaceutical company had to do with licensing. The patent still belonged to a different owner, so it was very costly to pay for that use. But what time has shown that there is no problem. Nowadays, we are convinced that tenofovir with emtricitabine or with lamivudine is equally potent. And that has been seen in all of the international guidelines where those options are very valid. So I don't see any problem that it is tenofovir plus lamivudine. Thank you very much. And I'm going to ask you a recommendation, something more practical about switch. We have patients that come with obsolete treatments or treatments that are not first line, as the case emtricitabine, tenofovir, efavirenz, or others. And there are patients with good tolerance that in whom no adverse events are seen. What do you recommend about switching? Continue with those treatments, thinking that they are tolerating them properly, and if there is any resistance, modify, or what would be the advantages to switch in those patients? That all depends on your personal practice. According to the guidelines, efavirenz-based therapies are considered obsolete today based on the evidence, superiority, tolerability, toxicity. But in that setting of a patient that has been tolerating for 1 or 2 years, is using a single pill, maybe the only concern I have is lipoatrophy. If you have a patient that is depressed, if you have a patient with problems, with mood problems, that is detected. If there is dyslipidemia, if there are alteration of liver tests, if there is suicidality, all of those variables can be assessed and avoided. But lipoatrophy, which is a hallmark of efavirenz, is something that once appears is irreversible. That all depends on the circumstances, the capacities you have in each one of the countries. whether the system is public or private. And also it will depend on the access you have to alternatives. And consider switch therapies that are safer. All right. Time is up. Optimum time as the antiretroviral treatment should be. I think that was the purpose of these presentations. I want to thank you very much for your attention. Thank you very much to these three great speakers that have given us an update. The idea of all this is how to optimize antiretroviral treatment. And I think that the word here is simplicity. Simplicity of dose, frequency, schemes, and that will have an impact not only on tolerance and safety, but in everything that is long run. That's why I believe that the immediate future is promising. And I'd say that the future is here today. Thank you again. And I would like to invite the audience to visit the virtual stand, and we will be waiting for you tomorrow, our third and last session at 11 a.m. in Santiago, Chile. And of course, every country should check the time zone. And thank you very much again. Thank you. Thank you. Goodbye, Juan. Goodbye, Alejo, Pablo. Goodbye.
El compromiso de Gilead por una eventual erradicación del VIH ha sido firme. Hemos seguido progresando constantemente con medicamentos efectivos que se han vuelto progresivamente más simples de tomar, más fáciles de tolerar y más seguros a largo plazo. Por lo tanto, el VIH se ha convertido en una enfermedad crónica tratable. En América Latina, cada vez más y más pacientes tienen acceso a nuestras terapias innovadoras que salvan vidas y mejoran su calidad de vida. Nuestro compromiso es permanente y aún queda un largo camino por recorrer, pero está en nuestras manos triunfar. Debemos continuar trabajando y hacer posible, y no solo lograr que nuestros pacientes sean indetectables, sino también a un estado de salud y bienestar integral.
Dovato, un salto a la nueva era en el tratamiento para personas viviendo con VIH. La potente combinación de 2 drogas en dosis fija, disponible en el mundo y hoy en Chile. Dovato, con la eficacia duradera y poderosa de dolutegravir. Alta barrera a la resistencia, con 0 mutaciones de resistencia versus un esquema de 3 drogas. Sin TDF, tenofovir, alafenamida ni abacavir. Dovato, el primer régimen en un comprimido diario basado en 2 drogas.